From almost a decade, and then again in 2006, it's amazing. There was this mad dash after 2000. Everybody got over Y2K as a non-event, dynamic non-event. And everybody got really excited about CPOE. Oh my gosh, to err is human and crossing the quality chasm. Let's do physician order entry in hospitals. How many places, first of all, there was tons of sales. I'm sure John's happy. There are tons of contracts around. People have bought a lot of CPOE. Less than 10% of hospitals have them fully live still 10 years later. But even the ones who have them live, what have they done with it? So the whole notion is this rat race that starts. Let's do this. We are a very buzzword oriented healthcare society. EMRs, adopt them now, not inpatient, ambulatory, everybody runs, just like chaos, and everybody's woe is me, and everybody's sad about the fact that nobody's coming to save me from all this hell and all that goes on. And so the point here is, even if you look at the IOM reports, it's amazing how much practicality is in those reports. So if you look at the one that I really like is about preventing medication errors, which happens to be half of, at least contributing to at least majority of those, vast majority of those deaths, is that they're talking about employ simple error detection methodologies. They're talking about understand how to detect before you harm the patient. And ultimately, they're not talking about EMRs, they're not talking about CPOE, they're not talking about buzzwords. They're saying use the information you have to improve this whole problem. They're not saying go buy GE, though I'm sure John would like to say that. But the point is, it's not about EMRs. And that's going to be my mantra today. So from my point of view, what responsibility a place like Duke has for the society? We are an academic medical center, so we're not a community hospital. I think we need to own up to our responsibility. And I believe our responsibility to become one of the self-learning health systems. We should show examples that it's not okay to resign to somebody else to fix our issues. It's not okay to say, oh, feds need to come in, or Blue Cross Blue Shields need to help me out, or somebody else needs to help me out. We need to help ourselves out. So the whole notion, I thought, and again, it's very interesting to go after Tim, who has this beautiful Apple-based, lovely slides, and here goes my complicated technical jargon. What's common between what he is talking about, and at least the way we thought of what he mentioned about behavior change, we decided at Duke we were not going to start thinking. We're going to stop thinking in silos, because we've always thought in silos. And so the notion is, for us, this site, which started with the clinical system, is incomplete without the discovery of medicine. One of the biggest issues of cost, which we haven't talked today about, is pharma. How does drugs get introduced? How does new therapies get introduced? They themselves, and lack of understanding of data around them, lead to so much issues around quality and safety. And people fumble their way through implementation of these things. All of a sudden, new drugs come on the market. They've been tested in this vacuum while they're tested on people. But so our whole notion is we gotta take this journey as much as possible, not through EMRs, but through the existing data that sits in our systems, link it around the patient, link it around a broader process. Stop thinking in silos. That, I think, is one of the fundamentals of design thinking we happen to come up on.